Thanks, Ramanan, and thank you for inviting me. Uh, I just have a few slides
Sure.
that I'll just quickly go through. So it's the problem, it seems, that was put on the table was how do you improve quality of care at scale in a cost-effective manner? And we heard about 6 strategies, and broadly, it seemed to me at least that these 6 strategies were very similar in that they're service-based, they're facility and context-specific, and they're very labor-intensive methodologies, right? So we don't have RCT evidence on these, and there were very key questions raised about what actually constitutes the quality of care. So what it seemed to me, I mean, at least in the work that we've been doing, the kind of 3 big issues we've been grappling with is when we think about quality of care, are we really thinking about a policy or a product? And within that, when it's policies, are we talking about health-related policies or non-health-related policies? I think one of the things that we're finding a lot is that the better, best, most cost-effective way to increase quality is to build roads because it gets people much faster into towns. The second issue has been, what's the study population? And the third is, what is measured and how is it really evaluated? So I just want to take you through maybe 5 minutes of how we've been thinking about this issue. And one of the questions that I want to think about at the end is kind of what are the implicit assumptions for scaling up that these kind of methods would actually invoke. And my caveat is most of the results here are from India and from primary care, so I'm not going to talk about either tertiary care or and I can indicate where we've done this work in other countries and what the results have been. So just a quick snapshot of what the current situation is, and these are all from data we've been collecting over the last decade. So India has about 4.4 healthcare providers per village. 77% have no formal medical training, so in the medical parlance, they're quacks. They account for about 70% of first contact primary care in India, and they're actually illegal. Less than 10% is public. 40% of public doctors are absent on any given day. The last decade, we've invested quite heavily in rural healthcare, and we've seen a 2 to 3% decline in nationwide representative samples of public facilities. And when we send in standardized patients, about 4% of patients get the correct treatment only, which is they actually got the right thing and didn't get something else. Fully trained doctors give the correct treatment plus something else 40% of the time. They give at least one incorrect treatment about 75% of the time, right? The big thing that we find, and this has now been replicated in Tanzania, Rwanda, Canada, and Netherlands, is there's a huge gap between what doctors tell us they would do with a certain patient when we ask them and what they actually do with that patient when we send that patient to them. And that gap, for instance, is close to 50 to 70% across all the illnesses we have tried. So diarrhea, what would you do with a child with diarrhea? I would give them ORS. 80% of doctors say that. 10% of doctors actually do it. The last bit of the current situation is the data. So these are public facilities that keep records. So we sent in about 231 standardized patients. We then did a record review 6 months later because we knew the name of the patient and the date they had visited. 74% of the facilities had at least listed that the patient visited. About 32% had listed the symptoms that the patient visited. And about 25%, the symptoms actually indicated what the standardized patient said they had. So we had cases where the standardized patient said they had chest pain, and they were listed as having a headache. So really, records in this context and data in this context are virtually non-existent or completely erroneous. So we've been doing this for about a decade, and my colleagues at the World Bank always ask, well, what should we do? And kind of thinking about the entire system, we've been struck by the fact that we really have 5 asks in a way. One is, we need to do something about the private sector. They're the only sector that are too big to fail in this context. They're providing about 80 to 90% of primary care. We need to work with informal providers who have no formal training. And by formal training, I mean they don't have a degree, but they've actually had a craft-based experience for quite a while. And many of them are actually orphans of government and donor projects that were meant to set up these kind of task-shifting approaches. So they get this 6-month training on becoming a nurse, and then they leave and set up their own private clinic. And on the evaluation front, what was very important for us was we needed to figure out what was under and over treatment. I mean, Ramanan's written eloquently about antibiotic abuse in numerous contexts. And we needed an intervention that cost less than $150 per provider. So this was very important for us. I mean, we've been doing some work in Kenya where we've been asked to come up with a product that's $100 to $125 per facility. Here we're asked was about $150 per provider. So we attempted a training intervention. This was with Abhijit Banerjee and Reshman Hussam at MIT and Abhijit Chaudhary. And our idea was, really we wanted to cut through the multidimensionality of quality and say, look, at first, what we just want to get is that when a patient goes to a healthcare provider, he or she should receive the correct diagnosis and treatment and should not receive treatments that are not required or harmful. I mean, that seems to cut, at least as a first step towards something in this multidimensional kind of beast. And we use standardized patients. So who are standardized patients? We recruit them from the local community. We train them for about 120 hours to depict the same medical condition to multiple providers. This is something everybody here is familiar with. And the design was of this training, which was actually 2 days a week for 4 hours a day for 9 months with multiple trainers, multiple approaches, a bunch of different things, was a randomized design where we randomized 304 providers into a treatment and a control group. And 6 months after the topics were taught, we sent in standardized patients with asthma, unstable angina, and childhood dysentery to these doctors. What was very important for us was actually the implementers were firewalled from the evaluators. So they did not know that we would send in standardized patients. They did not know the conditions that would be tested. And we were really going with a health systems approach rather than a vertical disease approach. We found fairly large impacts. So we have impacts of about 7 to 8 percentage points increase in correct treatment rates for what essentially are 3 illnesses picked from a hat. And it's 13 to 14 percentage points if you think about what would be the impact of full training. Very interestingly, we had no change in things that they should not do. So we got large increases in things that they were not doing, but they should. We had no changes at all in things like uses of antibiotics, polypharmacy, or injection use. And the cost of intervention, I mean, this is something that came up yesterday. One thing with working with the private sector is at least you can use a very stringent guideline, which says, even if you take out the health benefits, can we show that the economic benefits exceed the costs? And the answer in this was yes, because they saw an increase of about 2 patients a day, which meant they could recover if this was priced to market, the full cost of the training within 6 months of their practice. We also compared this to the 11 primary care centers in the 203 villages that these doctors came from. And essentially, the only place that the informal sector providers with no formal medical training were worse than the public doctors was that their correct treatment rates was about 15 percentage points lower. They were spending more time, they were doing more of checklists, they were giving fewer antibiotics, they were giving fewer injections, and the intervention cut that deficit by about a half to something that was, at the end, statistically not significant. So broad lessons for us, at least, has been, look, it is possible to evaluate in an RCD context a very complex, long-duration, multi-topic training intervention. And for us, it at least provides one benchmark for QI as the costs, so one way to think about it is how should the Indian government think about interventions in this sector? And it says, look, for about $175 a provider, which we are now working to decrease to about 125, we get about a 12 to 13 percentage point increase in correct treatment, right? So we close the gap with the public sector in treatment. The public sector was in 11 of the 203 villages where these guys came from, and these guys are in every village. So you could get fairly large impacts from this kind of systems approach to thinking about it. And it led me to think about kind of four broad assumptions that, Ramanan, coming to your ask, may be interesting, which is it assumes that the problem has been correctly diagnosed as a frontline issue. That has to be independent of potential policy changes or changes in the institutional structure, right? I mean, so the biggest problem in India right now is we really have a system where the public sector cannot acknowledge that informal providers exist. They're legally not allowed to exist from the Supreme Court's ruling, so they can never work with them. And yet they provide 80% of our care. And unless we move on the regulation and the discussion around the legislation and the executive action around this, it's really hard to change anything. The second assumption is that public sector interventions carry over to the private sector, which they might or might not, or will shrink the private sector. So the broad assumption here seems to be when we improve things in this hospital, 80%, at least in India, 80% of my care is outside the hospital, and what's going to happen is this intervention is going to draw in patients and shrink the bad sector. I don't know what evidence we have for that. The third is that the costs are sufficiently low for large and sustained scale-up within country budgets. Again, when we've been going to countries and asking them, what's your QI budget? They come up with 2% of a health budget, 1% of a health budget, and we get that down to how much is it per provider, and it's somewhere between $100 and $150 per provider, right? And the fourth is really that there's sufficient capacity and external validity for scale-up. I'm happy to talk through any of these issues in the discussion coming up.
Thanks, Jishnu. That's a great start, starting with both data as well as with these very important questions. I'll just ask one quick clarifying question before we move on. You said the 2 patients additional for the provider, that is drawing from other providers, or is it just you don't know where they really come from?
We really don't know where they come from. I mean, it's just saying, is this self-financing?
Is it self-financing? Okay, all right. Just wanted to check that. So thanks. So